Thank you. My name's Anthony Glover. I'm an endocrine surgeon at Royal North Shore Hospital. And in this talk, I'm going to cover workup of thyroid nodules. So I have no conflicts of interest. So besides being an endocrine surgeon, I have a number of other roles. I'm heavily involved in research into endocrine cancer biology and work at the Garvan Institute, and also involved with surgical education, running the Master of Surgery program. And thyroid nodules are something we see very common. So this might be a typical kind of morning in my clinic. So seeing patients with different types of thyroid nodules. Often they're incidental, as the first patient is being a 45-year-old woman who had a sore throat, saw her GP, and then had an ultrasound leading to a diagnosis of a small thyroid nodule. Or they can be symptomatic, as the second patient is being a 72-year-old man who had dysphagia and had a referral for a large thyroid nodule. There are some general principles about the workup of thyroid nodules. The first thing is they're very common. Most are asymptomatic. When we're assessing them, we need to consider what the patient's thyroid function is, what the risk of cancer is from this thyroid nodule. And to do this, we need to include a biochemical, clinical, and ultrasound assessment. And thyroid nodules, because they are common, they are often overtreated, and it's important that we understand the different nuances in treatment and the different ways treatment is changing, so we can personalize treatment for our patients. So what are the causes of thyroid nodules? Most of our patients will present with a multinodular goiter, which is having multiple nodules, more than 1 centimeter in the thyroid. And this is due to a response to the thyroid due to iodine deficiency. So Australia is naturally iodine deficient, and over a lifetime, if a person is deficient in iodine from their diet, the thyroid follicles will respond by having a monoclonal expansion of their cells to increase iodine uptake, which can lead to autonomous growth and a slowly growing nodules in the thyroid. Other common presentations can be due to Hashimoto's thyroiditis, where a patient may have a palpable nodular goiter, but generally the nodules are all quite small, under 1 centimeter on imaging. Cysts, which can be due to a degeneration of a thyroid nodule or a follicular adenoma, and can be hemorrhagic, colloid or simple. And then adenomas either derived from the follicular cells or Hürtel cells, and then malignancies in situ, which is NIFP, which has become a common diagnosis in the United States, but is less common in Australia due to differences in pathological assessment. And finally, malignancy, which can be present in up to 10% of thyroid nodules, and maybe up to 15% in certain series. So one of the key points to get from this talk are thyroid nodules are common, and they increase with age, with most patients under 30 years having an incidence of less than 3% of having thyroid nodules, whereas as people get older, there is much more common, and autopsy studies have found that about 50% of people will have thyroid nodules. Over the last few decades, the workup of thyroid nodules has undergone a number of changes, as have thyroid cancer. And this figure is from a recent review from Jerry Doherty and his team from Boston, and showing some of the key changes in both thyroid nodule and thyroid cancer management. So in this talk, I'm going to touch on these 4 in the red boxes, but really looking at how FNA is used in thyroid nodules, the use of ultrasound assessment for thyroid nodule workup, and molecular testing. I think the key thing is here, there's a lot of nuance in the treatment. and it is important to try and personalize treatment for each patient to avoid overtreatment. So with the initial assessment of each patient, it's important to start with a history and physical examination. So especially on the history, you want to ask about any exposure to ionizing radiation, especially if they've had radiation to the whole body or head and neck as a child, because that is a risk factor for thyroid cancer. If patients are under 30 years or over 60 years, that also will increase the risk of a thyroid nodule being due to a cancer. A family history of thyroid cancer, especially if they've had 2 first-degree relatives with thyroid cancer, that will increase the risk of a thyroid nodule being due to thyroid cancer, and is also thought to increase the risk of this thyroid cancer being more aggressive. Following your history on exam, you want to assess the nodule characteristics. Is it soft? Is it firm? Is there any retrosternal extension? Does the patient have any other nodules or a goiter? Are there any palpable cervical lymph nodes? Part of your assessment also is going to include thyroid function tests, and especially a TSH level. And if the TSH is suppressed or the patient has signs of thyroid toxicosis, then the first assessment should be with a radionucleotide thyroid scan to see if the thyroid nodule is autonomous or if there's a general cause for their overproduction of thyroid hormone. And finally, part of the assessment is ultrasound, which is mandatory for the assessment of all thyroid nodules. So on ultrasound, you're going to confirm if what you can see is what you can feel is actually a thyroid nodule, and then assess its sonographic features. Also look for any other thyroid nodules and any lymphadenopathy in the neck. You also want to look at how big the thyroid is, or its volume. So a normal thyroid should be less than 10 cc's, and if a thyroid volume is more than 30 cc's, it is likely the patient will have some symptoms from their goiter. You also want to carefully consider the relationship of the thyroid nodules and the thyroid to the adjacent structures in the neck. And finally, ultrasound gives you the benefit of being able to select nodules for FNA biopsy, and also identify any lymph nodes that should be biopsied. So this patient, one of the cases, so this patient had this 1.2 centimeter solid thyroid nodule, which you can see here on the right. So there's 2 different dimensions there. So the most useful classification to work up this thyroid nodule and decide how you should manage it is the TIRADS classification. So this has been developed with the American Society of Radiology, and it uses 5 different features to give scores. So you can see there's composition, the echogenicity, the shape, the margin, and any echogenic foci, such as microcalcifications. And each one receives a score, and the scores added up, and the nodule is either assessed as TIRADS 1, which has a very low malignancy risk and is not recommended for biopsy, up to TIRADS 5, which has a malignancy risk of around 35%, and is recommended to be biopsied when it is more than 1 centimeter. With these guidelines, and especially the management recommendations, it should be remembered that these are being designed for an American population, and working in an environment where many patients presenting with thyroid nodules will be overtreated. So they're naturally trying to reduce overdiagnosis on a population level. Further to this, many thyroid surgeries in the United States are done by surgeons that only do a handful of thyroid operations each year. And we know that there is a strong relationship between number of operations and outcomes, which these guidelines should also be considered with. So looking at these patients' imaging, so it's a solid nodule, it's hypoechoic. It isn't taller than wide, but it has a irregular margin, and it has some punctate microcalcifications. So this total score would be 9, which is Thyroid 5, which is highly suggestive of malignancy. This patient went on to have a biopsy, which showed it was a Bethesda 6 biopsy or a papillary thyroid cancer. There are a number of other different schemes you can use or guidelines. So this is quite a useful reference from the American Association of Endocrine Surgery guidelines, just showing you the ATA guidelines compared to the TIRADS guidelines. They can be useful depending on your practice. The ATA guidelines have a more permissive recommendation for biopsy, which probably better reflects our practice in Australia. So there are some specific circumstances, and I think our Australian practice doesn't always reflect the American practice. One thing is if nodules smaller than a centimetre should be biopsied, and I think they should in particular situations, especially when it's highly suspicious for a thyroid cancer. In other talks we'll talk about thyroid cancer management, but for some patients with small thyroid cancers, they may be suitable for active surveillance. So it's important that we have a diagnosis for these patients and also exclude other rarer histological subtypes, and also assess exactly where the small thyroid cancer is. There are certain locations of the thyroid which are not suitable for active surveillance. As shown is these images, which is from a series from Memorial Sloan Kettering in New York of patients that had small thyroid cancers presenting with invasion of their recurrent laryngeal nerve. So especially when you're considering these patients, they should be referred to a thyroid specialist who is used to treating these patients and assessing these patients, and ideally performing, either you performing or they performing the ultrasound themselves. So especially considering is this small thyroid cancer or suspicious nodule next to where the recurrent laryngeal nerve runs? Is there any extrathyroidal extension? Are there any evidence of metastatic lymph nodes? The other situation with small thyroid nodules is FNA is indicated if there's a family history, any genetic syndromes, presentation of young age or childhood radiation, or if it's the patient's preference for it. The other indication would be to consider is nodules bigger than 4 centimeters. They're increasingly likely to cause symptoms, and there's a bigger risk of malignancy as the nodules get bigger. So generally, those patients will be either considered for biopsy or for surgery for diagnosis. So for any patients that do not meet the criteria for a fine needle aspiration biopsy, they should be followed up. There's the evidence for how they should be followed up isn't that set, but this is kind of been suggested, and this is how I generally will practice. So if you have very small nodules that patients do not want, they're suspicious nodules that patients don't want a biopsy, I would usually follow it up in 6 months or 4 to 6 months to see what any change in growth in that nodule, and then at either 12 months or 2 years for lower risk nodules. When you're sending patients for fine needle aspiration biopsy, it's important to know your results. When you receive your report, mostly all labs now in Australia will use the Bethesda classification, which is 1 to 6. And there is some variation with the results of these results in red are from a pathological series from my hospital at Royal North Shore, published a few years ago now, but just showing the experience of our pathology service and what their rates of malignancy were. So Bethesda 4 was suspicious for follicular neoplasm. In this series, there was a rate of malignancy of 15%. Bethesda 3, or atypical nodule, was a risk of malignancy of 9%. So it's important you understand what your lab's results are. because there can be some variation. And generally, once you have your biopsy, it makes the management clearer for your patients. But there is some nuances, as we have discussed. One area that's developing is the role of molecular testing. So some labs in Sydney now are saving the biopsies for molecular testing, which can be performed, but is required to be sent to the United States and be funded by the patient. Generally, it costs about more than $2,000, and it's suitable for B3 to B5 nodules. And the ideal idea is that it will increase your accuracy of knowing whether it's a malignant nodule or it's benign. So these are two examples of a B4 and a B5 nodule that were found to have mutations associated with thyroid cancer and highly likely to be thyroid cancer and managed as such. So just going back to my two patients, my first patient had, as I said, diagnosed with a B6 biopsy, so diagnostic for papillary thyroid cancer. She had a family history of thyroid cancer on review. So she had a total thyroidectomy with a prophylactic central lymph node dissection. Was found to have an intermediate risk cancer due to lymphovascular invasion on pathology, and then went on to radioactive iodine ablation and remains disease-free on follow-up with TSH suppression. My second patient had an enlarged thyroid, being 60 cc's, just some small nodules on the right, with the left dominant nodule being benign. He went on to have a left hemithyroidectomy with resolution of his symptoms. So I think just finishing up, workup of thyroid nodules. Thyroid nodules are very common. Most are asymptomatic. When we see these patients, we have to include an assessments tailored, thinking about thyroid function, the risk of cancer, and the clinical, biochemical, and ultrasound assessment. Most of these patients probably will not require surgery, but they do require specialist care, and we need to personalize our treatment and avoid over-treatment. So thanks for listening. I'll look forward to taking any questions on the panel, and my contact details are there if you want to get in touch. Thank you.